who is going to speak on the subject of the knee, and Dr. Avtar Singh, who is also going to speak on the subject of the hip. Both are very senior, eminent persons in the field of arthroplasty, not only nationally but internationally also. And we are lucky to have them. I am Dr. Dipak Dave, along with my colleague Dr. Dhanasekara. We, on behalf of the Education Committee and on behalf of our Managing Trustee Dr. Vikram Shah, our President Dr. Indrajit Sardar, Secretary Dr. Leo Joseph, the members of the Executive Board, our trustees, and our patron Dr. Pachore, I welcome both these speakers, and I'm sure this will be a good learning experience for all of us. I thank both the speakers for sparing the time and decided to be there here on this program. So the first lecture is by Neeraj Adkar, the eminent robotic surgeon from Pune, and he is the organizers of the Pune Arthroplasty course. So he conducts this course in Pune, you can understand, and has got a long list of the robotic surgery and other things on his behind him. The main thing is going to talk on these implant selections in the TKR, primary and revision. So with wide range of implants available, sometimes we are confused which will be the right implant for this particular case. So without wasting time, I request Dr. Neeraj Adkar to start his presentation, which is going to be about 15-20 minutes. Then we will have a question-answer session. At 7:45, we'll request Dr. Avtar Singh to join, and
recording in progress.
Another session will be there. So, Dr. Neeraj, can you share the screen and start your talk? On behalf of myself and Dhanasekara, we welcome both of you.
Yes, sir. Can you see my screen?
Yes.
Yes, yes.
Okay. Yes. At the outset, I would like to thank Ishks, Managing Committee, and Education Chair Dr. Dipak Dave, Dr. Dhanasekara, and all the office bearers for having me here. Implant selection in TKA is a very important topic, not just for beginners, but for all seasoned surgeons also, and it is extremely crucial. TKA is one of the most successful surgeries in the history of orthopedics, we can say. And patients, they are nowadays we are seeing a lot of young arthritics, and they have high expectations from the surgery, and often they tend to abuse the joint. So we need to provide them joint which will give them good range of movement, at the same time which will last long. That is very important. So that's why implant selection is very crucial in TKA. So broadly, this can be classified into unconstrained implants, for which we use for primary TKA, like cruciate retaining implants, posterior stabilized implants, medial pivot, and mobile bearings. And constrained, like non-hinged, constrained implant, hinged, and limb preservation system. So CR versus PS, that debate is going on since past 4 decades. And there are hardcore CR surgeons, hardcore PS surgeons. But we need to understand some basics, why CR is important. You know, PCL, all of us know, it provides rollback for the femur, it improves posterior clearance, and it improves in quadriceps momentum. It gives that near normal feel to patient if you opt for CR implant. But PS, there are distinct advantages where it is more predictable kinematic, controlled rollback, and especially in your early stage of your career in orthoplasty, it is easier to balance the knee with PS knees. But you need to resect more bone, and it's difficult to treat femoral condyle fractures if there are any because of the resected bone in the box cut. There are issues with cam post mechanism which we notice in some patients, and increased shear forces. CR, it gives near normal feel to the patient, and because of the intact neuroreceptors, that normal feel is there. Less bone resection is very important, especially in Indian scenario, in small anatomy. So that is distinct advantage. But if you don't balance it properly, then it will be a nightmare, and it is challenging in CR scenario. So if you don't balance, then it may lead to accelerated polywear also. Excessive deformities like more than 10 degrees of varus, more than 15 degrees of valgus, it is challenging, and that is relative contraindication for CR. There are distinct contraindications like prior high tibial osteotomy, prior patelectomy, inflammatory arthritis, rheumatoid arthritis, severe deformities, as I said earlier, and PCL deficient knees, you cannot perform CR implant. So results are similar if you go through the literature, CR versus PS, whatever implant is working well in your hand, it is surgeon dependent, and CR definitely should be avoided in early stage of your arthroplasty career. That should be very clear. All poly implant is made up of polyethylene, and there is no metal base plate. It is fixed bearing implant, and it is a monoblock implant. It can be used in mild to moderate deformities, non-obese patients with good bone stock. These are prerequisites for all poly. Definitely, it is a cheaper, and there are no issues with locking mechanism as we see in metal back implants. So when we insert the poly on a metal base plate in conventional metal back implant, there could be some poly locking mechanism related issues, which are definitely avoided in these monoblock all poly implants. And for same section, you get thicker polyethylene as compared to metal back implant. But less modularity, you cannot use same and wedges with all poly. You don't have option of mobile bearing implants. And if something goes wrong, scenario of like PGI, where you definitely would like to go for liner exchange, that is not possible in all poly, and it is definitely technically demanding. So early stage of your arthroplasty career, again, avoid this implant, and conventional metal back is definitely safer. Metal back, it is modularity is better than all poly. Liner exchange is possible. Mobile bearing, so fixed as well as mobile, both options are there in metal back. And you, if required, you can use frames, wedges, and it is more forgiving as compared to all poly. But it is expensive as compared to all poly. There are issues with backside wear and increased tensile stresses at the interface during eccentric loading. So this paper by Ranawat et al. And they concluded this is recommended in in younger and active patients and intermediate follow-up. So they got good result in all poly. Another patient, another paper where they concluded superiority of the modular metal back implant remains in question. Uh, Coming to mobile bearing implant, where this insert is mobile and it is not fixed to the metal base plate. Nowadays, very few companies are offering this, but this gives near normal feel to the patient, improved range of movement, as claim came by many companies. But as all of us know, post-op range of movement is actually dependent on your surgical technique and not the implant. Again, your pre-op range of movement is very crucial. So post-op ROM frames is directly proportional to pre-op ROM. But this mobile bearing definitely helps in wear reduction, and it is independent of tibial base plate rotation. That is very important. And whenever you are using mobile bearing, the size of the liner or the poly is based on your femoral size, not on the tibial size, like we do in metal back fixed bearing implants. It is definitely patella friendly because of the mobile insert. Patella tracking is definitely better as compared to fixed bearing implants. But there is a learning curve associated with this implant. Chances of pin out are there if it is not balanced properly. It is costlier. And various studies they have proved that there is no difference in range of movement and wear reduction as compared to fixed bearing implant. And extension stains wedges, that addition is not possible with mobile bearing implants. Medial pivot is a ball and socket where the medial ball and femoral and tibial condyle is articulates, and it gives single curvature radius. So that gives a good range of movement. It is and in this implant, anterior and posterior lips of polyethylene are enhanced for stability. So Medial pivot reduces contact stresses and polyethylene wear. It improves prosthesis survival by maximizing contact area between polyethylene insert and femoral prosthesis. And it does not need intercondylar box to accommodate columns. So less bone resection is required. Uh, Coming to high flex implants, which are marketed by few companies, where there is increased posterior slope in insert or in base plate, and some of the implant unit excess posterior femoral condylar resection, like in PS 150 from Depew. But honestly, again, it is post-op ROM depends on your surgical technique and pre-op ROM. Remember that, okay? So this will give you a little bit of advantage, but not significant, not supported by the literature. Oxinium or opulent implants are indicated in patients who are having metal sensitivity towards cobalt chrome. Again, they are suggested in relatively younger age group, where the life you need to plan for 20, 30 years ahead. But various studies, they are not proven in favor of the implant, where the longevity is better than conventional cobalt chrome. But definitely they are indicated in patients with metal allergy. Vitamin E, impregnated poly helps in reducing wear and tear. Coming to now extension stem from primary, we are now slightly moving towards revision scenario. Extension stems are indicated even in primary cases where there are large defects. There are some deficiency of the collateral ligaments, osteoporotic bones. In all revision surgeries are indicated. Obese patients, now we use routinely short cemented stems in osteoporotic and obese patients. We have very low threshold to go for short cemented stem, and that really works. And post osteosynthesis or HTO patients, definitely extension stem is required. This patient, 62-year-old female, she had typical varus knee with severe osteoporosis, and we use short cemented stem, and she's doing well. So instead of long stem, short stems are indicated in such scenario in osteoporotic bones. Another patient with moderate deformity with osteoporosis and short cemented stem was used. So long cemented long extension stems are indicated in such cases where there is some associated fracture, severe deformities, and so they are uncemented stems. Short stems are always cemented stems. Cones and sleeves in TKA are used in revision as well as in primary. Primary with huge bone defects, and revision scenario with a lot of bone loss. Uh, Whenever we are doing any TKA, we should remember that we should have secure fixation in at least two zones. So zone one is surface and epiphysis, zone two is metaphysis, and zone three is diaphysis. So out of these three, two zone we need to have secure fixation. Then only that implant will last long. Remember that. So cones are they have encouraging data short to mid-term. I feel the biggest advantage of cone over sleeve is it is not implant specific, okay, and it can be used in uncontained defects. Sleeves are in use since 1970s, and now since 2008 we have fully porous sleeves available, and they are made of titanium. Either they can be cemented or uncemented, and they are poro-coated, which induces new bone growth, and which gives really solid hold in metaphysis. So patients with such defects, metaphyseal sleeves are boon, and they definitely help in restoration of joint line, especially in revision scenario, where we can, with good hold of the sleeve, we can keep base plate slightly proud close to the native joint line. So they give rotational stability and excellent in metaphyseal defects. Important thing is they're independent of orientation of the components. So we can put the base plate and sleeve irrespective of their, the version, rotation. So sleeves where you can have good bone stock, where you have good bone stock, in that direction you can impact the sleeve, and it is very simple technique, and that gives really rock solid hold in the metaphyseal region. Interesting case here, 75-year-old lady, she was diabetic and hypertensive. She underwent bilateral TKR 7 years ago. But unfortunately, she developed infection in her right knee, which led to arthrodesis. Okay. So she was just walking on her left side, left knee, and it was functioning knee, nice, working well. But she had fall and sustained fractured tibia. So this knee was working well, and it was a well fixed femoral component PFC implant. In this case, we just converted that with long stem and sleeve in the metaphyseal region. We retained the native or primary femur, and we could get excellent results. So opposite side, it was fused knee, and this was the knee which she was walking, and she was back on her feet in around 6 weeks time. So whenever we are dealing in a revision scenario, Anderson classification is very handy. And type 1, they are content defect where they are managed with cement or impaction allograft. Type 2A and 2B, again, cement, augments or small bone graft. For type 3, definitely needs customized implant, mega prosthesis and sleeves. So type A is minor defect, as I said, and without compromising stability of the components. So collaterals are intact here and they're content defect. So typical scenario of type Anderson type 1, where you can get away with a standard implant, routine implant. Type 2 is metaphyseal bone and damage, but more important here, the collaterals are intact. So you don't need implant like hinge prosthesis. So typical type Anderson type 2, where there was huge uncontained defect, which was treated with impaction grafting and offset stem. Another patient where this, nowadays we are getting a lot of patients like this, where this uni was done couple of months earlier somewhere else, and it unfortunately did not work well, and there was huge defect, and which we converted with using max PCK system, and where you have option of offset same, and this is how we did, and the revision with semi-constraint implant here and primary femur. So she in fact got good outcome, and if you remove these revision implants, the native implants carefully with minimal bone loss, still you can get away with the primary implants in revision scenario. Anderson type 3, the collaterals are damaged. You need hinge prosthesis. Let it be very clear. So this classification everyone should know whenever you are dealing with complex primaries or in revision scenario. Patient type 3, 67-year-old male, and he developed UTI 4 years post index surgery, and he landed this like this at our hospital. Actually got stuck in COVID, and he could not plan his revision surgery for nearly 1 year. And this is his post-op X-ray with the sleeves and hinge prosthesis. Another patient, implant removal and spacer, and another same with sleeve prosthesis. Interesting patient, 37-year-old lady, rheumatoid. She underwent all poly TKR 3 months back at some other hospital, and she already had a supracondylar fracture, and she developed infection with this implant. So it's a nightmare. So we had to remove the plate as well as the implant and static spacer, and this is how it was converted. This was done in 2011. Now 13 years follow-up, and she's still doing well. Another opposite side, same lady, we used all polyprosthesis, which is, and these are her post-op range of movements. Another example of T3, F3 Anderson category, 72-year-old patient. She developed cellulitis 3 years post-surgery. Implant removal and spacer was done, but unfortunately, she had a fall on that spacer, and this is how she landed again. With the spacer was dislocated and fractured, but we did not have any other option but to convert that with LPS. So in such cases, comminuted fracture, we need to have LPS as backup, and that is actually only choice she had, and she's doing well. Patient underwent bilateral TKR 8 years ago. All poly. She had road traffic accident. This is how she presented. Comminuted distal femoral fracture, and on table this bone was completely crushed, as you can see, and it was difficult to construct that back. And it was very soft bone. We decided to convert that with the LPS, and these are our post-op X-rays, and this is the post-op day 15 gate. So friends, to conclude, AORI less than 10 mm, go ahead with cement. We can construct plus minus screws. More than 10 mm, bone graft, same, wedges, and constraint implant. And type 3, you definitely need sleeves and hinge implant. Okay. And implant selection is extremely important. In your early stage, start with PS implant. Constraint implant you must use in post-osteo osteosynthesis cases. All poly CR implant, mobile bearing in experienced hand only, or when you are used to TKR, then only venture with these implants. Thank you very much for your patient hearing.
Thanks, Neeraj. Before we see on the chat the questions coming in, I have just two important announcements. The next session is on 12th of October, Saturday, same time, 7 p.m. Please note the date, 12th of October. We will be having two eminent speakers, Dr. Sharan Patil and Dr. Pradeep Bhosle, for this session. Second, we request on behalf of the executive board and the trustees, all the delegates, the surgeons, young surgeons, and to contribute to the Ishks registry. Please try to send all your cases and help to improve the number in the Ishks registry. So these are the 2 points I want to appeal to everybody. By the time we get the questions on the chat box, Neeraj, my question is to you. Do you think that addition of vitamin E in the poly and this oxygenate gold surface, combination of these two, whatever design you have a CR, PS, medial pivot, but these two independent factors will be very helpful in the longevity? You think so?
In fact, sir, there are certain papers recently where they say oxynium and they have early failure. So it is still, jury is still out, I would say. But we suggest them in young patients and patients who are having, they are known allergic to metal iron. So patient says my bracelet dalta hu to itching hota hai, or some necklace there is issue. So such patients definitely we should offer them these implants.
Okay. Dr. Kincha is there?
So, Dr. Neeraj, what is your basic working implant, which is a commonly used implant in your surgery?
I use PS implant and routinely CR dip dish. In fact, I use, but post-op I could not find much difference, to be very honest with you. So I'm more of a PS surgeon.
Can you see the question answer chat box? There is one question on the tibial slope.
No, sir, I'm not able to see that chat.
So, will tibial slope influence hyperextension or FFD?
Will tibial slope?
Will tibial slope influence hyperextension or FFD?
See, if you ask me, distal femoral cut is more relevant in this scenario than the tibial slope. Restricted flexion or then obviously we increase the tibial slope. But for hyperextension, we reduce the distal femoral cut, and FFD also we need to increase the tibial femoral cut. So the distal femoral cut is important in both this scenario than tibial slope.
Yes, Dr. Avtar Singh, your comments
Dr.
on the
Neeraj,
topic.
any experience with the ultra congruent insert?
So ultra congruent, we used it. I mean, Donjoy, they had that DGO knee, and which was ultra congruent insert they used to offer. They had a very brief stay in India, unfortunately, but it works well actually. So
Maybe small rheumatoid patients where we cannot
yes,
take box, we can use it.
yes,
It's useful especially in patients who have osteoporotic bones, and
Yes.
you shouldn't cut a box.
Yes.
It's very, very useful in those patients.
So,
Actually.
and these patients, we can obviously we can deep dish implants, insert. We can sacrifice the PCL
Yes.
and need not reset the box. So medial pivot system available in India. Biorad is offering that. DGO they had earlier. So these
Yes.
two companies are offering and
No,
medial pivot.
congruent is available from one company called Plus Medical. So it is there in India, and I'm using it since last many years, and I'm happy with that.
The question is replacing the patella, is it out? So you replace, I mean, anterior knee pain percentage is same. But if you go through the literature, then they say the chances of resurgery are less if you replace the patella. But I have been a non-resurfacer for and all these years, and I'm not facing any issue. Make sure that you don't stuff your patellofemoral joint. Whether you resurface patella, you don't resurface patella, that is very important to avoid any patellofemoral symptoms post-operatively.
Yeah, you rightly said it's the anterior offset which matters.
Yes.
When you do the anterior cut, if you make less anterior cut, then you are stuffing the anterior compartment. And then you have to go in for a bigger femoral component. So make it sure that your anterior cut is flush with the anterior cortex, and then I don't think we need to replace patella. So I normally don't.
Dr. Dhanasekara, as
Yes.
Dr. Neeraj is not replacing patella, my question, anatomical patella and this dome-shaped patella, you think there'll be the difference in the tracking, the function, the pain, movement, staircase, this patella design, does it matters? What is your opinion, Dr. Dhanasekara?
So this Attune has offset patella, and also Smith and Nephew, they have this offset patella where the center is slightly offset, not in the center of the patella prosthesis. So it helps in tracking better, than the extent of incidence of lateral retinacular release is reduced by shifting the center slightly medial. So that's helpful in good, better patella tracking. But need to be very careful because we have previously had a symmetrical dome-shaped patella. So if you make an error in rotation, it took care of it. But now we need to align the patellar prosthesis perpendicular to the patellar tendon and make sure it is tracking in the proper position. So though it improves patellar tracking and reduces the extent of lateral release, it has a problem if you change the rotation. So that also you need to keep in mind.
Okay. Question regarding gap balancing and measured resection.
Gap balancing versus measured resection.
So what we practice currently is combination of both. So we measure the cuts, distal femoral and the upper tibia, and so it is never actual just gap balancing or major dissection. It is combination of both.
Actually, this gap balancing, they have dedicated instruments where they do the flexion gap balancing first and then do the extension gap balancing second. That is actual gap balancing technique. They don't bother about the alignment in extension. Once your flexion gap is balanced, they bring the knee into extension and do the resection. So that is the actual gap balancing technique. But what we do is we balance the knee in extension And then when you go to the flexion, we can rotate the femoral jig to match your flexion gap so that you don't need to release much of your soft tissues in flexion. So that's what we follow. It's a combination of mesoresection versus with the gap balancing.
Neeraj, a small word on the uncemented knee.
Uncemented, I had used in 2018-20. The PFC implant was there available that time. But at the moment, I'm not using uncemented. You definitely need very good bone stock for that. And that time also we had that hybrid. I mean, femoral was uncemented and tibia was cemented implant. I don't have much experience with
your
uncemented.
experience on this uncemented or hybrid?
No, I have never done uncemented or hybrid experience with that.
Dr. Raja?
No, I never used uncemented.
2018, we did one bilateral uncemented PFC, and that was a CR knee working well. But I think it will come back again uncemented. So let's see.
It's the cost factor which is hindrance.
Yes.
And any of you
There is one
doing some ceramic knees, because now it's available in the country.
I don't have much experience, or I mean, I have not used it.
Right.
There is one question, Neeraj. When specifically you would prefer rotating platform? I think you already answered that. But any specific indication for rotating platform?
See, there are no specific indications as I mean, so all these implants fixed versus rotating platform, all those, I mean, both implants can be considered. But there are distinct advantages. It is patella femoral joint friendly implant, and it gives that normal feel because of the rotation. That's it. I mean, there is no specific indication to use rotating, but rotating hinge in revision scenario makes your life very easy. So otherwise, it is impossible to use fixed pairing implant in revision scenario. Rotating hinge definitely works well.
I think more it is indicated more in when you increase the constraint to reduce the stress on the interface. We use rotating platform. When you're using a CCK or a TC3 type of implant to reduce the stress on the fixation, we combine it with the rotating platform. And all the hinges now come with the rotating platform to reduce the stress on the fixation.
Hinge.
Otherwise, in primary TKR, rotating platform, that is very individual preference. Some are very happy to use a rotating platform, but most of us use fixed bearing. And elderly patients, if you have a rotating platform, sometimes they can feel like giving way. You need to understand that it is a problem and are using for elderly patient whom have a very not a great motor control. Otherwise, the results wise, I think both are almost similar. There are no difference in rotating platform and fixed bearing. So how do you, there's another question, how do you ensure joint line when metaphyseal defect are present both in the femoral and tibial side?
Meniscus usually gives fair idea about the joint line. That is one anatomical landmark which is used very frequently in primary scenario. Revision, we can measure from the epicondyle, and same distance we need definitely need to reproduce.
I think mostly the meniscal remnant will be there in revisions also.
Revision also.
If it is there, that is the simplest method to identify the joint line. If you don't have that, 3 centimeter from the medial epicondyle or 2.5 centimeter from the lateral epicondyle is the landmark. Or you need to see the lateral view of the knee, 1 finger breadth below the lower pole of patella. That is another landmark for identifying the joint line.
Okay, I think that should be the end of this first session. Neeraj, me and Dhanasekara Raja, and on behalf of the Ishks Executive Committee and trustees, we thank you for spending your time and be here for this talk. So thank you very much, Neeraj.
Thank you.
And
My
I
pleasure,
request
sir.
I request Dr. Dhanasekara Raja to take over for the next proceedings talk, introduce Dr. Avtar Singh and take this session forward.
So thank you, Dr. Dipak. I'd like to invite Dr. Avtar Singh. He's a senior orthopedic surgeon from Amritsar, and he's a director for the Amandeep Group of Hospitals. Has extensive experience in joint replacement, more than 30 years of experience, and he has a large experience using dual mobility in hip arthroplasty. I welcome Dr. Avtar Singh to give his presentation on indications of dual mobility in present-day hip arthroplasty.
Thank you, Dr. Raja, and good evening, everyone, all the friends. And I'm grateful to Ishks for giving me the opportunity to share whatever little experience I have in the dual mobility. Friends, I'm using this dual mobility since I think 2006, and I have no regrets. Just let me.
Good.
No.
Slide.
Yeah, I have to go to the first slide. Yes. एक मिनट काका हाँ ठीक है thank you it's okay friends you'll be happy to know that the global hip replacement market was valued at 7.33 billion in 2021 and it's going to be 10 point something billion by 2028 at a very rapid growth annually. And most of this growth, if you look at the yellow towers, it's coming from Asia, and out of Asian countries, India and China, they are like neck to neck in the numbers. And then good contribution coming from Japan and other Asian countries. So whenever a patient undergoes a hip replacement, his expectations are a good functional outcome, minimal dislocation, long survivorship, and it should be cost effective. And as a surgeon, we also aim for all these outcomes. And when we think about the hip replacement, we have three options: hemi, total hip replacement, and now total hip with dual mobility cup. And we can choose the implant according to the age, medical conditions, cognitive status, lifestyle, and socioeconomic status of the patient. And now the literature is clear that THR, when we compare this with hemiarthroplasty, it gives us much better functional outcome. Timing is almost the same, just a difference of from 15 minutes between the two procedures and little more blood loss, but functionally it's much better. And then THR group has significantly lower complication rate as compared to the hemi group. So there's no doubt about that now, given that you choose your indication rightly. Although THR is one of the most successful procedures, but there is a problem with this, that's the dislocation, and it can go up to 10% in the primaries, and it can go up to 30% in the revisions. And it's a major cause of readmissions and revision surgeries. And sometimes it can damage the reputation of a surgeon as well. So there are many factors which lead on to dislocation: the patient factors and the surgeon's factor or the surgery factors. There are many patient-related factors, starting from THA done for fracture neck, femur, or in rheumatoids, or the greatest risk factor is the previous hip surgery in any indication, then high body mass index, low body mass index. Very frail patients also have higher dislocations than patients having neurological disorders like Parkinsonism, polio, cerebral palsy, etc. Then a new disease has been highlighted now, that is spinopelvic alignment. They also, if the spine and pelvis, they have some abnormality, they also tend to have higher dislocation. Then large number of failed osteosynthesis, abductor insufficiency, AVN, dysplastic hip, and patients above. So it's a long list. And then there are operative risk factors like surgical approach. A regular posterior approach surgeons, and I don't find any difference in my practice. The main reason for the surgical dislocation is malposition of the components, or if you use a small femoral head, or if you don't give proper tension to the soft tissues, or decreased femoral offset, or decreased femoral head neck. These are the operative risk factors. And then there are known strategies to minimize the dislocation. You need to repair your soft tissues nicely. You need to maintain a soft tissue balance. And your cup should be within the safe Linux zone. But then remember that many of the dislocations, they have the implants within the safe Linux zone. And then there are implant modifications. You can use large femoral head, posteriorly raised, or the lipped liner, what you call, or you can use constrained acetabular component in some of the indications. And then now the most popular out of all these options, dual mobility cups. Then friends, why not have one implant for all high risk patients? Which should have least dislocation, long survivorship, better functional outcome, and cost effective as well. And that implant is there in the world since I think 1978 or 74, and that's dual mobility. And this idea came from France, and it got US FDA approval pretty late, actually. I don't know the reasons for that. And I started using this implant 2006. So Giles and Bosque from France, they came out with this brilliant idea. They just did one thing. They married two brilliant concepts of Chanley and Mackay and Farrar, and they came out with dual mobility. So what is actually dual mobility? It's a metal-backed shell which may be cemented or uncemented, and it's polished from inside. Then prosthetic head, 22 to 28 millimeter, which is within a retentive polyethylene, and that polyethylene articulates with the outer cup. So it's cup within a cup or head within a head kind of situation. The mobility happens at two joints. The first mobility happens in the inner joint, and that gives you around 76 degrees of movement with a 28 millimeter head. And normally this is what we need for most of our daily living activities. If you go beyond that, then we'll need a dual mobility kind of situation. And the second mobility happens in the outer shell. You will see it in this video. It's very clear. Initially, the movement is within the smaller head and the poly, and then between the poly and the outer shell. So biomechanically, a study was conducted comparing all the options, standard, constrained, and dual mobility, and highest range of motion to impingement came out with dual mobility construct. So this is the most stable construct we can have for arthroplasty hip. There are two types of dual mobility cups, basically cemented and non-cemented. And now in non-cemented, there are designs which have screw options to get proper fixations in the very beginning if the hold of the bone is not that great.
I'm happy you asked this question.
More modifications are being done in the dual mobility. They are coming out with ceramic liners or with oxynium liners. And one company like Smith & Nephew is coming out with now ceramic on ceramic dual mobility. Surgical technique is very simple. It's like you have this press where you push the metallic or ceramic head into this retentive poly. So not difficult. So if you look at the outcome in the literature, dual mobility has given much better functional outcome when compared to hemiarthroplasty in all the series. And it gives you much better functional outcome when you compare it with standard THR in most of the series. So there is no doubt about the superiority of the dual mobility cups whenever indicated. And there is much lower risk of dislocation using dual mobility cup when we compare the standard THR and hemiarthroplasty with dual mobility cups. So it scores over these regular competitors in all the ways, the function-wise and dislocation-wise. And this study shows that there is relative risk of dislocation using dual mobility is 59% less than hemi and 83% less than conventional THR. So there is a huge difference. And many studies are there now in the literature, with the longest being 22 years and with very, very low dislocation rate. No series exceeded more than 3 years, 3% of dislocation. And there is a unique complication to this dual mobility, and that is intraprosthetic dislocation. And that was more common when we used to use 22 millimeter head. And now, since most of the heads are 28 millimeters, so this dislocation, intraprosthetic dislocation incidence has gone down dramatically. We published our own study, 240 patients in fracture neck femur a couple of years ago, and we had just 3 dislocations in 240 patients for fracture neck femur. And now in my practice, whenever a replacement is indicated after fracture neck femur, my first choice is dual mobility cup, which may be cemented or non-cemented depending on the quality of the bone. Coming on to the complication of fracture neck femur, even if you fix it well, sometimes they fail, they get into non-union, and then you can again do dual mobility. Especially in these failures, dual mobility is a better implant than all other implants, because after any previous surgery, the chances of dislocation are higher. Many of you must not have seen these surgeries. Like this was the standard procedure, the osteotomy for treating fracture neck femur. This patient came to me a couple of years ago with pain. So I placed him with dual mobility and cemented cup. Another operation which was very common long time back was Goldenstone. This was standard operation in some of the institutions for fracture neck femur, and they can all be converted now to dual mobility with no problem with the dislocation. One of my own patients, which I fixed, this patient had a fracture neck femur associated with subtrop fracture. I did this surgery twice, but again it failed. And then I did a dual mobility and a long Wagner, and this is 1 year follow-up, and he's doing very well. Now coming on to fracture neck femur in patients having neuromuscular disorders, they are at a high risk of dislocation because they have neuromuscular problems. And there are 3 studies who have done dual mobility in these patients with fracture neck femur with almost 0 dislocation. These are 2 of my own patients. One was polyaortic and the other was cerebral palsy patient. And they're doing so well after dual mobility. Another example of post-polio residual palsy and a subluxated hip on the right side. He had polio on the left side. If you do a regular THR in such a scenario, you will have a higher dislocation because your spine is wobbling from side to side. Then dual mobility is a very good option for such patient. And I had to reconstruct the acetabulum with the femoral head and then did a dual mobility and a short stem. And he's doing pretty well now. Then coming on to avascular necrosis patients, they also have a higher dislocation rate, almost 1.5 times than the normal population. So there are many studies now who favor use of dual mobility in avascular necrosis with almost zero dislocation. And if my patient is, say, above 50 or 55, I regularly use dual mobility cups, non-cemented. And in young patients like this patient, he was around 55, I tend to use a combination of small stem or short stem and a dual mobility. I did this dual mobility and a molar stem in 2007 when patient was around in his 50s. And then he had aseptic loosening 2017, and the poly was absolutely the same when I inserted it and when I saw it 10 years later. So there was no wear and tear in that. So few other patients with dual mobility, because most of these patients who come from a particular background, they ask for higher range of motion. They want to squat or sit on the ground for their prayers. So it's an ideal implant for these patients who are into their 50s or 60s. Now coming on to the revision THR, everyone knows that dislocation rate can go up to 30% in some of the series. And there are reasons for that. Most common reason is the previous surgeries that lead to weakness of the muscle, fibrosis of the muscle, and that leads to more dislocation. And then bone loss sometimes can force us to put your implant in a particular position, which may not be ideal, but then there is no other option actually. So in these situations, the best implant again is dual mobility, and most of the series, the dislocation in revision scenario is less than 3%. And few of my own patients, aseptic loosening, revised with the trabecular metal and a dual mobility insert. And even in recurrent dislocations, dual mobility is ideal, and there are studies favoring that. Like this study, he had only one early dislocation in a series of 59 patients. So that's a great outcome. And it's my implant of choice now for all my revisions, whenever we can implant a normal cup. So a couple of my own patients advised with dual mobility and doing very well. Another interesting way of converting a normal THR into a dual mobility. This fellow was 80 years male, done about 15 years ago. You can see the bicontact stem. I used to do this long time back. And he came back with multiple dislocations within 6 months. And then when I went inside, there was no loosening of the cup. The stem was perfect. The only problem was the laxity of the muscles. So I did a cup in cup dual mobility. I used the normal cup and a dual mobility cup and put a cement in between. And a small video for that. You can see this cement and the dual mobility cup. And he was absolutely stable. So what could have been a major surgery turned out to be a very small surgery. Just put a cement and put a dual mobility, and he's absolutely fine now. And then coming on to more patients, like the hemis, if you don't do it for the right indication, they are going to fail within 5 years. So many of them, they come for revisions. Like they fail in different ways. They can break, they can dislocate, they can cause erosion of the acetabulum, and they become painful. And then you can revise all these with dual mobility cup, which may be cemented like this or a non-cemented. and a long stem of different shapes, whatever is available with you. And it is highly recommended that we can use a dual mobility whenever there is a failure of hemi because of dislocation. These severe trauma patients, a dislocation, a fracture, and damage to the head. You cannot safely fix these fracture and hope for a good result. They will have a painful result if you go in for internal fixation. So it's better to replace them with the dual mobility cup and a long stem, bypassing the fracture, and it healed perfectly. So then now, sorry to say that many half-baked surgeons, they are doing trauma in the field, and many of them, they fail and they come for revisions. And these patients will have higher rate of dislocation because of excessive fibrous tissue formation, damage to the muscle contracture, and sometimes deficient abductors. Look at these patients. They were neglected patients and you cannot fix them. So they will not have good abductors as well. So it's better to do a dual mobility in all these patients, and you can choose the stem accordingly. Then trauma will fail in different ways because there are many kind of implants now available in the market, the nails, the plates, the proximal femoral plate, and so on. But when they fail, then replacement with a dual mobility and a long stem is the ideal solution for them. Another patient, badly infected, you can actually see the bone through the wound and look at the X-ray, infection all over, and she was related to one of my residents. 2-stage. The first was spacer, and then about 3 months later, we did a modular long stem, non-cemented and a cemented dual mobility, and she's now about 6 years down the lane. Another very interesting patient, 20 years male, neglected fracture dislocation, because he had so many other injuries. These are the bed sores, and he had injuries on the leg and on the foot, a young chap. And he had all the necrosis of the skin on the thigh. So I'm lucky to have a good team of plastic surgeons headed by Dr. Abhi Mahajan. He excised the dead tissue and he replaced this initially with a skin graft. The child survived ultimately, and then we decided to replace the hip, and he did a fasciocutaneous microvascular flap, which did well, healed. And then this was done about 6 months down the lane. I had to do shortening of the femur, but I could save the trochanter area, put it back, a modular stem, and a non-cemented dual mobility. And now this is 8 years follow-up, and he's now able to walk. All his other injuries have healed, and you can treat all these neglected fractures, fracture dislocations safely with dual mobility cup after some reconstruction of the acetabular defect, and you will not have sleepless nights. Then we published our study of dual mobility in using dual mobility in all these high-risk patients, and we had great outcome. We just had 2 or 3 dislocations out of 111 patients. Then it's a very safe bet to use dual mobility cup after tumor resections. Normally, tumor resection and THR has a higher dislocation rate into 30s, but with dual mobility, it comes down to 9.8%. And if it's still lower, if you can preserve the abductors, and it's higher if you have to resect or section the abductors. It all depends on that. Then in obese patients also, it's an ideal choice if your patient is above 50 or 55. And it has been found that with standard liners, risk of dislocation is higher in obesity, and pre-op bariatric surgery will not decrease the risk of dislocation, and use of dual mobility liner or constrained liner is more effective. So don't wait for the patients to undergo bariatric surgery. Just do your job and come out of that with dual mobility cups. Like these patients, they like this particular gentleman, he wanted to sit on the ground, and I could ensure him that you can sit on the ground. That's not a problem, because this was available with me at that time. This was about 15 years ago, and he was a happy patient. Then osteoarthritis, again, middle-aged patient, ideal choice. And if you have a fracture to canter associated with osteoarthritis, again, this is a very good choice for these patients, long stem and a dual mobility. And DTH, again, middle-aged patient, it's a very good choice. And Coxavir, again, you can use this cup safely. And in a very thin patient, again, these frail patients, they have a higher chances of dislocation because they have very little muscle mass. Again, dual mobility is a safe bet in these patients, and very little dislocation in all these patients in a series of 199 patients. And in dementia also, these people have higher chances of dislocation, so it's safe to use in dementia patients as well. Then coming on to spinopelvic disorder, this is too big a topic to be discussed today, and it's safe to use dual mobility rather than the standard conventional cups. One of my patients with stuck sitting kind of hip, and we did a bilateral short stem and dual mobility. This was done about 3 months ago, and he's okay with that. Coming on to complications, dislocation is a rare complication. It's less than 1% in most of the series. We had a couple of them. And once you get a dislocation with a dual mobility, it's difficult to reduce with close reduction. Remember that. And some of the patient, you may have to open up and do the open reduction. And then a complication which is unique to dual mobility is intraprosthetic dislocation. It used to be there in elderly patient, and it was more common when 22 millimeter head was used. And now most of the head are 28 millimeters, so the chances of this dislocation have gone down. Mostly it was chronic, but now some of the patients, they can have it in acute situation. I will share one of my own patients. And treatment for this is always revision surgery. You cannot treat intraprosthetic dislocation conservatively. One of my own patient, she had a fall, came back with this. We thought it's a simple dislocation, but if you look at the X-ray carefully, you can see the bubble sign. We attempted reduction, but you can see the head is eccentric, and you can see this bubble sign. So that's the indication of intraprosthetic dislocation. We did a CT scan, and you can again see this bubble very clearly. So that means we have to go in and revise this. And this is what we got on exploration. And I could see that my cup was also a little more vertical than needed. So I revised the cup also. And we revised the head and the insert also. And I changed the position of the cup. And this is what we got post-op. And she's doing well. And now, last few slides about, let's talk about the wear. Do they wear more because they have more than one articulation? No, they don't wear more. Rather, the wear is as low as the cemented polyethylene liner, and it's lower than or equivalent to non-cemented liners. So you don't need to be afraid of wear and tear in dual mobility cups. It's validated now. I'll share one example of my own patient. This patient had a bilateral AVN. He was young at that time, and he got this. Somebody did a bipolar in a very young patient. This was done in 2007, and he came back to me with a broken stem on the left side. You can see this. So that's not the way we should treat our hip patients who are young. So I revised this because he wanted to sit on the ground and squat. And those days I had the dual mobility. I did a long stem and a dual mobility. He did very well for 17 years. Then he came back with, you can see the osteolysis in the upper part of the femur and ESR CRP normal. CT scan again shows osteolysis here. I went in fully prepared for the total revision, but then when I opened him up, I was surprised to see a pus-like fluid coming out of the capsule. Initially, I thought it's frank pus, but then I got the gram staining done because we don't have frozen section at our disposal. The gram stain was negative. And then I just took the bone graft from the same like crest, pushed it into all the cavities. And then I tried to analyze the reason for this wear and tear. It was this skirted neck which led to this polywear in this patient. You can see it was a mistake to use a skirted neck. This skirt kept on eroding the poly over the years. And I revised this with the new poly, and after putting the graft in the cavities, and I did axanium head, and now I could see that this head is not touching your neck. So now this is about 1 year down the lane, and he's doing well now. So coming on to survivorship at 10 years, it's great for all ages, except patients who were less than 55. They again did well. They were having 92% survivorship long term. And all the studies show very little dislocation in the primary and in the revision scenario, and again intraprosthetic dislocation, very low rates. And now if you look at the usage of dual mobility all over the world, now they're coming close to the conventional hip replacement. Indications and usage is increasing. And if you look at the cost, although in our country it's a little more expensive at the moment, but if you compare the long-term studies, it turns out to be cheaper than the normal implant. And if you use this implant in patients who are less than 80, this turns out to be cheaper than the conventional. If your patient is above 80, then it's more expensive. And look at the publications. Every year they are increasing, and now they are close to 100 publications every year. So that shows that it's being used more extensively now. And if you look at the joint registries, again, the number is increasing and is being increasingly recommended. So friends, take home messages that this cup has got extensive clinical history, very high survivorship, no more polyethylene wear than fixed bearing, and much less dislocations than fixed bearing, and very simple operative technique. And if you look at the French registry, more than 1/3 of their cups are now dual mobility cups. It's definitely a cup for patients who are at higher risk of dislocation. And I'm sure that with improved poly and improved designs, this will be again much more successful than the conventional hips, if your indication is right. Thank you so much.
Thank you, Dr. Avtar Singh, for extensive coverage of dual mobility.
I'm sorry I took a little more time, I think, but
Yeah, but you have extensive experience and you showed all difficult cases. So we'll look at the questions. There's already a question there.
okay.
Can you see the question? You can stop sharing.
Yeah, the first question is, what is my experience on constrained liners in recurrent dislocations? I have never used a constrained liner in my life. Initially, it was not available and to my hospital, and now I don't need it actually. I've never used it. I will use it only if I had to resect all the abductors and I'm deficient with the soft tissues in a tumor situation, then definitely I will use this constraint liner.
So can you stop sharing so that you can see your face?
Okay. Okay. Right.
So one problem with the non-modular dual mobility, you don't have option to put screws.
Yes.
How do you manage those situations?
No, I have both the options in my theater. In cemented, there is no problem, but when it comes to the non-cemented, initially I had only one option, and that option never had the screws. But that cup from Evolutis, or the initial cup which I used from Plus Medica cup had two pegs and a small attachment for a screw over the top.
Yep.
But you are right. In certain patients, when your bone quality is not good and you want to use a non-cemented option, and if you don't have screws, then it's a problem in some very few of your patients. I do get these problems, but then I have a bailout situation. I have even trabecular metal cups in dual mobility, or you can convert that into a cemented cup, dual mobility cup. So that's not a problem. But then that leads to waste of that particular implant which you have opened. But that's a very rare situation.
Okay. So how the survivorship of cemented dual mobility in your experience?
I have revised only one cemented dual mobility in my practice. And apart from that, I never had to revise a cemented dual mobility.
So if somebody wants a primary hip replacement,
yes,
and they are at high risk of dislocation, you use a dual mobility.
Yes, always.
But if they are not of high risk, but they want to squat down, sit cross-legged, will you use a dual mobility for them?
You see, if a patient is very young with no comorbidities, like I'll say 50 is my cutout, even if they ask for that, I will not use that.
Okay.
In those patients, my first choice will be a regular cup, but with a bigger head. And now 32 is supposedly the best head diameter for all patients.
So in a neuromuscular patient, does the abductor strength influence your choice, or how do you decide?
No, definitely these patients like polio patient, which I showed you, they're not ideal patients for a regular kind of DHR. They are best patients for dual mobility. And same about the cerebral palsy patients. They are not normal patients. They will always have higher dislocation rates. So we need to protect them from dislocation. And about the polio patients, if they have no power in the hip abductors, then they should not be replaced. But still, if you have to replace them, then again, the dual mobility is the ideal option.
Maybe 3/5 will be a cutoff.
Yes.
At least eliminating gravity, they should be able to abduct.
Definitely.
So there's a question from Dr. Pachore.
It's
monoblock stem in revision
situation. How will You lock the dual mobility.
So if you are not revising the stem,
Yeah.
you're retaining the stem, changing only the socket or only the liner. How do you lock?
Lock means?
Lock the dual mobility. Your head is probably non-modular head. That's what.
No, the locking is done on the table actually. You have to push the head into the poly on the table.
I think he's asking about Chanley. Sometimes you have a well-fixed Chanley. You are not changing the step.
And with Chanley, though, I will always take out the Chanley and put maybe a different stem with a 12-14 cone and then use the normal head and dual mobility over that. With Chanley, you cannot.
But I have done in a couple of situations. I have locked it, keeping the locking device on the over the neck and then locked it. Luckily, I was able to do.
Maybe. But I've never been into that situation. If I am in that situation, I will knock out the Chanley and then do cement on cement.
Is there any scoring system which guides usage of dual mobility cups?
No, I'm not aware of that.
Basically, you assess the risk of dislocation and decide, and age.
Okay.
There was a big list you gave initially.
Yeah.
So patients should be taken as high risk, and
you see, in our practice, we are getting two kind of patients. One is the young patients with avascular necrosis. That's the most common indication for our hips in India, unlike abroad where they have more osteoarthritic patients. So young avascular patients, I will not use dual mobility, but if they are beyond 50, then I will use this because they then fall into a higher dislocation rate patients.
AVN in athlete should be offered dual mobility.
Yeah.
Dr. Avtar Singh,
yeah.
Excellent presentation, and I think most of the viewers will now try to jump to dual mobility after watching and listening to you.
I think they should.
I mean, it's a very good implant, but if we go through the literature, it is not recommended for primary THA and less than 50 years of age.
Yes, definitely. I don't use it in young patients unless it is like really indicated. Like I showed one patient who was young, but we had no other options. We had to resect the proximal femur and then replace that. And that's now 8 years down the lane.
Yes. So that is one thing which I think all of us should remember, less than, because still the long-term result as compared to the conventional THA are not there. So, and we are adding.
I agree with the long-term result because there is now 25 years follow-up available in the literature.
And we are adding one more interface here. So that is one concern which is there in the literature. So,
from that's a theoretical concern. I have opened some of these patients and I could see no damage to the poly actually.
Okay.
I think the message is very clear. He clearly says it is not for patients less than 50, for a minor THR, for a AVN.
Yes.
High-risk patient with the risk of dislocation, you will use it for a younger patient. More the elderly patient, you can safely use
That's what, and if you use it for younger patients, then we should have a ceramic head rather than a metallic head.
Yes.
That's one change we can make.
And if we are contemplating THA in fracture neck femur, then that's the implant of choice, dual mobility.
Absolutely.
Rather than the conventional THA.
Yes.
Yeah.
So, with that, can we conclude the session if there are no more questions?
Yes, please.
So I thank Dr. Neeraj and Avtar for joining today and sparing their time and giving excellent lectures. I thank Dr. President Indrajit Sardar for joining the session. Dr. Dipak has to be away, and I think Dr. Pachore is online. Sir, would you like to comment anything?
Hello.
Yes, sir.
Yes.
Can you hear?
Yes, sir. Please go ahead.
Yeah. Certain things important is regarding the abductor mechanism. If there is no abductor mechanism, there is no role of dual mobility, it will dislocate.
Yeah, definitely.
I think we have to, Avtar, we have to keep option of what is called constraint as a last resort, which is not good, but we have no choice.
Yeah, I agree.
Secondly, Chanle stem, what Raja has told is right, that we have done a couple of Chanle, keeping them intact, 35 years, which my boss did about many years back. So I kept the Chanle and I was able to lock the dual mobility cup. So
Sir, just teach
yeah.
me how to put dual mobility over the Chanle. Does it fit
Chanle,
into?
it is possible.
Okay, great.
It is possible. There is a mechanism of two spanner, which Vijay Bose has described.
Okay.
So I'll send you some film for that. It is possible to do it. So you unnecessarily don't do a massive surgery for this elderly group of patients.
Right, I agree.
Possibility is there. Yeah.
And
I totally agree with you. And this message has to go to the youngsters that all intertrochanteric failed fractures, a very high rate of dislocation. I think that's a good choice for dual mobility.
Right.
I just want to ask you one important thing. What you described was that pus like coming. That was not a pus. This is osteolysis.
Yeah, it was osteolysis.
Something like that.
Yeah. I realized that.
And not to worry. And all the youngsters should know that they should not close the wound with a debridement. So you can. This is a liner exchange. What you need. These are the old poly which has done all these problems. I must have revised a good number of these polys, and they were not cross-link polys. That has produced very massive osteolysis.
Right.
Second important thing, before doing these cases, probably you can give what is 4 or 6 doses of demersimant so as to increase the quality of the bone, and then you can go inside liner exchange.
Right.
And it was a good thing you informed the youngsters that once this dislocates, you must keep option consent for the patient for open reduction. That is very important to have an open reduction. I was stuck once with this. So I think that is option has to be kept, because this is not possible. It will sometimes de-lock the whole thing, lock whole thing. I just want to ask you, cemented dual mobilities, what is your take on that?
I mean, I'm very happy with cemented dual mobility. In fact, I'm using it since last 10 years when this Evolutis company started providing me with cemented, and I have no issues with that. And now I have cemented from 2 companies. One is Evolutis and the other one is this Plus Medica company, Per Medica, from, I think it's from Italy. So both are good implants. And this Per Medica cemented cup has even elevated posterior wall. So that further saves us from the dislocation. And I just had one aseptic loosening. Apart from that, I never had any complication.
By and large, people are not happy with that cemented cup, because the loosening rate looks to be very high, because there is no interlocking mechanism available, micro interlocking. So that is a little problematic.
If you look at the back of these cups, they have quite deep grooves on the back side. So I have never had any problem with that, actually, apart from one patient. And you see, all these patients, most of these patients, they are in the age group of 70 plus. So if we tend to use non-cemented option in these patients, many of them, they will have loosening.
One caution regarding modularity of the dual mobility, which many companies have. There are certain reports which are coming, is the ionic metal, cobalt and chromium levels are getting slightly high. So that is little worrying part of it. I don't know what is your view on this.
You see, I'm also worried about the backside wear between. It's like metal on metal kind of on the backside.
Yeah, that's right. Because micromotion will take place.
Yeah, but I have never, to be very frank, I have not worked on this aspect of this design of dual mobility. But so
And,
far,
okay.
I have no problem with that.
Our registry data also shows, surprisingly, the higher numbers of dual mobility used in our own registry of our Indian registry.
Right. So that's a good news that the people are now picking up the idea of dual mobility now.
Yes, yes. It is quite a numbers are coming on dual mobility. Is increasing year-wise use of dual mobility.
You see, it's increasing worldwide now. It's a worldwide phenomenon.
Yeah.
I think
And
with a lot of post-traumatic hip problems and revisions numbers increasing, probably the dual
Yes.
mobility numbers have gone up.
Right. So that's a welcome change actually all over the country.
Okay, sir. So can we
Thank
conclude?
you, Avtar. Thank you very much.
Thank you, sir. Thank you so much for giving me the opportunity.
So thank you, everybody.
Thank you very much.
Thank you, sir. Thank you. Thank you.
So before we close, I would like to announce that next meeting will be on October 12th. So please join. Who are not registered can register and join. And thank you, everybody, for your participation. And good night, everybody.
Good night.
Good night.
Good night.
Good night. Good night.
Good night.
Recording stopped.